Please welcome Professor Louise Newman.
Thank you very much for the introduction, and thank you, of course, for the invitation to come along and speak at what looks like such a rich conference. So I hope very much that this is a good opening for you as you think over the coming presentations about the reality of trauma in the lives of children and young people. And that's one of the issues that I'll briefly address this morning and maybe ask us to think about as we go through some of the seemingly ongoing difficulties we have in acknowledging trauma in the lives of children, and from my perspective, particularly the very young. We still have difficulties acknowledging that many children are already impacted by trauma, by parenting breakdown, by attachment disruption by the time that we see them, and yet we have very little in the way of dedicated services for traumatised children, or even a focus on trauma in many, and I'm talking largely about mental health services, which is where I'm situated, obviously. So I think these discussions have a lot of implications for the current rather controversial issues that we think about trauma-related mental health, particularly funding, the key issue that's bugs most of us on a daily basis, but also service models. What sort of service models do we actually need to better respond to the needs of children? Should all our mental health funding, or the majority of new funding, seemingly be going to youth services? This is a very controversial issue at the moment, but I don't think anyone's arguing that youth don't need services. The issue is maybe about how can we broaden the discussion to actually look more at prevention and what early intervention might mean if we could intervene as early as possible, which of course is my bias, which I'll declare right at the beginning, and we can argue about it later. The earlier the better in terms of psychological and emotional well-being. Preventive approaches, how do we get funding for prevention as opposed for treatment of already established conditions? But also, how do we improve our knowledge about trauma-focused approaches and validating people who have experienced trauma from infancy to adulthood? And in many ways, our services still struggle with that. I will say a little bit about diagnosis as we go on, and really highlighting my particular view on this is that we need diagnostic frameworks that can talk about trauma in a much broader way, and that we're at risk within our current diagnostic systems, at least in mental health, of trying to delineate syndromes out of context. So particularly things that you'll be familiar with, attention deficit hyperactivity disorder and many other conditions that children might be diagnosed with, which seemingly are caught like the common cold, have no context. Parenting and the child's experience of trauma is not thought to have much to do with it. So that's putting it in a provocative way, but I think it's an important issue. So there's a science behind this sort of argument, which I'll say a little bit about, and some of you will be very familiar with it, that early trauma can have significant impact on both psychological and neurobiological development. There is an increasing body of evidence that early abuse, toxic levels of stress impacts the developing brain. That the things that we end up, at least in mental health, calling the symptoms of various disorders might be better thought about as some of the developmental sequelae of quite significant early trauma. So the common things that we struggle with in mental health and child services: children with so-called difficult behaviour, children who find it hard to regulate their emotional states, children who are struggling to understand how human interaction works, how relationships work, children who are primarily oriented around survival, who've come out of dangerous environments. Those are not easy things to actually intervene in, but they're the crucial things that will impact on children's lives and functioning. And very important, I believe, to think about those in terms of the way trauma and trauma-related hormones have impacted on the developing brain. So the message, and I hope to get this across, is that as in all our work intersecting with children coming from dangerous and difficult environments, we have a responsibility to name trauma, to actually speak out about the trauma that these children have experienced. Whether it's fashionable in terms of diagnostic systems or government policy, so be it. But that's our role in terms of advocacy work for children. We need to broaden our thinking about our trauma response. Of course, we need safe and effective services. That would be a good start. But we also need to think about ways of validating individuals' experience. So whether that's a child or an adult survivor of abuse. In many ways, people are still struggling to have their reality acknowledged. This is one of my experimental subjects, a happy and healthy volunteer baby, but obviously even someone of this age. And this baby has not experienced trauma, but can be particularly negatively impacted by breakdown of caring relationships, by frightening and inescapable experiences. And maybe that's the way of thinking about trauma in the very young. It is essentially inescapable. It's also non-verbal in that child has not yet got the capacity to talk about or put into narrative form what's actually happening or happened to them. And trauma is literally inscribed into the fabric of the developing brain and psychological functioning, even from birth. So obviously, early development, current models of early development are focusing on infancy, the period where our brains are growing at their most rapid rate in the lifespan, the sort of the 0 to 3, 4 age group, where focusing on the social context of development. So infants' brain development, psychological and emotional development occurs in the context of attachment relationships, of caregiving relationships. The way in which those relationships function or maybe don't function is crucial when we think about the emerging capacities and development of the infant in terms of understanding relationships, regulating their own feelings. And of course, we clinically focus on emotional interactions, disturbed patterns of emotional interactions, and they can be disturbed for various reasons. Most commonly, and I think this is child abuse work, we're very familiar with the concept of transgenerational trauma. So in work very early in the lifespan, we frequently are seeing parents and carers themselves who've experienced abuse, neglect, disruption, and sometimes abuse, who struggle to establish secure relationships, sensitive relationships with their own child, despite often being highly motivated to do so. And I think it's very important that we acknowledge that many parents with so-called, histories of abuse and neglect, so-called maltreating parents, are highly motivated to parent effectively, and that is the very painful dilemma that they face. And many of the young women I work with will actually put that into words very clearly. I would like to be an effective parent for my child. Can you tell me how to do that, because I don't know? And a terrible sense of deficit or not being able to set up the sorts of caring and protective relationships that they would like to. So we do know that experiences early in life, early adversity, relates very clearly to the burden of mental health and social problems that we see. We're very familiar with that. We're learning more about the mechanisms involved, and at a very micro level, if you like, some of the key problems that people who've had these experiences face will be at the level of human interaction. Understanding how relationships work, being able to understand emotions in the self and in the other person. We all need these skills every day. We meet new people, we meet people we're trying to connect with, we make judgments about people. We're using very complicated brain circuitry and psychological capacities to understand other people, to try and read them, to read the mind in the eyes is the way it's sometimes described. We make eye contact with people, we try and figure out, is this a safe person or not? And many of the abuse survivors that we work with struggle with that, and they frequently make poor judgments in relationships or fail to pick up some of the cues. And all these things, very important mechanisms and things that are set up very early. So current thinking, as you'll be aware, is about the longer-term effects of trauma, and particularly trying to understand this notion of critical periods, when trauma really can have major implications for psychological and neurological organisation. Infancy is not the only critical period, although I work in that end of the lifespan. Adolescence and some of the very crucial brain reorganisation and changes that are going on, particularly in the frontal lobes of the brain in adolescence, is another very critical period. So these are opportunities, but they're also periods of increasing risk. So if we think about the insults that the very young can experience, obviously that's setting up impacting negatively potentially on the basic wiring of the brain that we need for healthy functioning. In adolescence, the adolescent brain will also be vulnerable, and increasing interest in the effects of obviously drugs and alcohol on the adolescent brain, and potential, again, long-term implications for development. So the infant brain research, and I'll only gloss over this today, but has been very important in understanding the mechanisms, but has huge implications for our decisions. Decisions about child protection, decisions about child and family policy, and I think very important in the current climate where we see various groups of high-risk infants. So trauma is actually one of those big words that gets used a lot. Hard to define when we're thinking about, let's say, non-verbal children or the very young. But maybe the easiest way to think about it is the notion that trauma, whatever it might be, are experiences that overwhelm that individual's capacity to manage them at their particular age. And this is a very general but quite a useful way of thinking about it. We need to think about what protective mechanisms children and young people have at various ages. Now, if you're a little baby and you're in a frightening and terrifying environment, your capacity to respond to that is obviously quite limited in some ways. But what we do see in the very young are the use of mechanisms such as dissociation or cutting off from reality, being hypervigilant, being on the lookout for danger. So whatever the age of the infant or child, adaptive mechanisms are important. Adaptive mechanisms can be very useful at that particular time. They may not be helpful in terms of long-term emotional and psychological well-being. So if you think about dissociation, a common enough mechanism where the young animal, and it occurs in non-human species as well as humans, in the face of danger, off or plays dead, a freeze and play dead response that you're probably familiar with, and some of you might have seen even in the very young. Quite a startling and clear response when we see it. Now that's a mechanism that helps and obviously is designed and built into us as a survival mechanism, but that is not helpful across the lifespan. And many of the adults that we work with who are survivors of significant abuse can still have that response in the face of something that triggers or reminds them of previous abusive interactions or states of fear. And that is not necessarily going to be the sort of way of managing stress and trauma that we like to see in adults. But what it shows us is that these things can be very persistent. So the patterns of defence that are set up in early childhood can actually be persistent later in the lifespan. So trauma is hugely significant in terms of longitudinal functioning, and we know on the basis of quite significant studies that we see overrepresentation of survivors of trauma in all our mental health, correctional, social services, as you'd be very familiar with. Just a couple of reports that you might want to have a look at in relation, if you want to follow any of these issues. I've recently been involved in the NHMRC clinical practice guidelines for so-called borderline personality disorder, of course a response to complex trauma. Those are out. They're quite a useful review of our understanding of some of the issues there, but particularly in relation to treatment of people who've experienced trauma. And I chaired the so-called expert reference group on borderline personality disorder for the previous Department of Health and Ageing, and that should be being put up shortly on their website. But that report again is a review of approaches and current issues as we try and think about better responses to help people. And the Adult Survive Child Abuse report is a very important report of a consumer-based organisation of abuse survivors, and again looks at best practice guidelines and interventions, and a very useful review. So any of those might be of interest. Obviously trauma varies, and we won't be talking about the impacts of single overwhelming events or today. But in our work, obviously, we see most commonly chronic and enduring stressors, usually in families of origin, trauma at the hands of attachment figures or those who are meant to be acting as attachment figures, indirect exposure, so the effects of domestic violence, witnessing attacks on the primary carer. All of those things have significant impact on child development. And interesting, if you look at the literature about domestic violence, indirect exposure, the impact on children is pretty much identical from direct, when compared to direct abuse of children. And that's largely because of the attachment context. So for the young child, witnessing attacks on their primary carer, who they are dependent on for both physical and psychological survival, of course, is pretty much identical to being having an attack on the self. And when we think about the long-term implications of trauma, it's those attacks on self, interactions which invalidate the child's experience, which fail to respond to the child's need for care and security, that are going to have these very long-term impacts. And as I mentioned, we see all the time transgenerational trauma. Now, the significance of all of this in current debates, which is what I wanted to mention a little bit about, is that there's I think increasing evidence that early adversity, broadly defined, we think about disruption of care, breakdown of attachment relationships, changes of carer, right through to child abuse and neglect, set up what we might think of as neurovulnerability to the entire range of mental disorders. So we've moved a long way from the debate that was going on, and some of us are old enough to remember the debates about child abuse being a simple causal factor leading to disorders X and Y, but usually things like post-traumatic stress disorder or borderline disorder. I think what we're seeing now is having a much broader understanding of the impact of stress and maltreatment on neurological functioning overall. And we still don't know why person X might end up developing one particular condition and person Y develops another. There are obviously lots of other factors involved in that. But if you look in a simple way, not that it's statistically simple, but look in a simple way at the association between early adversity and mental health problems in adult life, there's an association of over a third, so over 30% of the burden of adult mental health problems can be related to early adversity, but not a single diagnosis. So very important to think about the breadth. Now, what that means in terms of interventions is also very important. That some of the earliest interventions we do that focus on helping parenting, helping emotional interaction, helping babies and young children have a sense that they're responded to in a containing way are things that we like to think, and we need to get the evidence for this, things that are neuroprotective. So it might be that this evidence helps us think about treatment approaches that are stress regulating. And we've done some preliminary work in looking at mothers with a diagnosis of so-called borderline personality disorder, so highly abused, highly stressed parents, very much wanting to engage with their infants. And we're looking at stress regulation in quite young babies, so under the age of 2, and finding that even at these early ages, these babies who are exposed to sometimes inconsistent or puzzling care, sometimes see their parent depressed or anxious, are having their own difficulties in regulating stress, and that will have longitudinal, potential long-term impacts on them. It's not telling us about any particular conditions they might have, but we're looking at very early vulnerability. Now, to me, being simplistic, this suggests that some of the government mental health funding might be better off put into these very early high-risk situations. Now, the onus is on us who work in the field maybe to get better evidence about the longitudinal pathways. But why wait until adolescence? When, sadly, and I do some work with very high-risk adolescents in secure welfare facilities in this state, we're seeing the final product, if you like, of extreme trauma, and we all struggle to know how to treat and intervene. And sadly, many of the so-called problems and symptoms that some of these vulnerable young people are presenting with probably relate to neurological dysfunction. And we've all seen cases that the system struggles with highly abused young people reenacting in the most ghastly way what has happened to them, being re-victimised, seemingly seeking re-victimisation, being unable to engage with care and support services, and we can all think of cases, I'm sure, that come to mind in that scenario. I get asked to see them when they're struggling, these young women with little babies who already in the first few weeks of life are suffering because of the profound disturbance of their parent and a system that finds it very difficult to know what to do. So that's the politics of early intervention, if you like. How can we, if we have a model that tells us more about these complex developmental pathways and outcomes, then maybe we need to be thinking about how better to do something with that. Now, part of the issue is that our diagnostic systems, particularly in psychiatry and mental health, are not very good on trauma. It's remarkable, really, but we have PTSD and we have, in some cases, a model of personality disorder. And in terms of DSM-5, the new system, which you might have the joy to read and probably do read every night, it's on the bedside table. Sadly, DSM-5 did not take up a condition which many of us thought, if we're going to have a new condition, might have been a more important one, about developmental trauma and the complex responses to early trauma. Didn't get up. That's the politics of it. So we haven't really advanced much in that way. So around about, if you look then at people in mental health facilities, the adult population, around about 70% have histories of early trauma. And we don't often ask about that, again, surprisingly. If we think someone has a condition that might be a psychotic condition or something that's the focus of treatment, the focus is on that, rather than thinking about what other factors in people's early experiences might be contributing, maybe not to our understanding of the disorder, if you like, but certainly need to be a focus of care and should be a focus of our attention. Of course, within mental health facilities, we also have safety issues, and there has been significant concern, particularly about the safety of women and the vulnerability of women and young people within systems of care, and young people and others with histories of significant abuse, of course, are at elevated risk within facilities. We've all got, again, sad examples of that. The risk, of course, then, is of ongoing trauma, re-victimisation. We also struggle to deal with adolescent presentations and the issue of disclosure of abuse and trauma. In the adolescent inpatient unit where I do on-call, which is a unit, like many of them, designed for supporting young people, maybe with psychotic conditions or other acute presentations of mood disorder, for example. About 80% of our people in the unit at any one time are presenting in crisis related to disclosures of sexual and other forms of abuse or family breakdown. So there are acute issues relating to disclosure, how we respond to that, and how we better deal with young people who may be presenting in that way but are not yet able to disclose. So they might not be at a stage where they're putting that into words, but they might be presenting with a crisis around self-harm or suicidality, for example. So these are very current and serious issues. So, neurovulnerability I mentioned, the last point is about some of the language that we use within mental health services, which could also be, from my perspective, reviewed. And this is an issue, of course, for many consumers, particularly those who get what has become, sadly, a stigmatising label, such as borderline personality disorder, which really means person that we find difficult and don't get on with. And it fails to describe what these people are actually struggling with. Memories of trauma, intrusive thoughts of early experiences, difficulty coping with emotions, particularly negative emotions, and so on, the things that we actually see when we have a proper dialogue with someone. So how do we bring in a consumer perspective around trauma and child abuse issues? It's a major issue within mental health services. And there have been some very recent and important consumer surveys looking at people with child abuse histories and their interaction with hospitals, mental health services. On the whole, very damning. Very negative perceptions that people have. Of course, there are exceptions, and we need to look at those and think about what works better for people with these issues. So, early trauma, we all pay socially and in terms of our systems and individuals, of course, a huge price. The economics of child abuse, many of you will be familiar with, but this is obviously a significant issue, not just within health, but of course across all human services. And these are the key issues that we struggle with at the moment. The experiences, as I mentioned, of early trauma, the best way to think about them is how they're inscribed in the fabric of the developing brain. So the brain remembers trauma in terms of its organisation. So the model really in a simple way says that being stressed overly during critical periods of brain development will set up certain response pathways and vulnerabilities in the face of later stress and adversity. So what do we see as a result of this? Now, from my perspective, and I'll, I think, try and argue that if we know that someone has experienced trauma and they have psychological or neurobiological difficulties, maybe it's easier just to think about that as a trauma syndrome, a post-trauma syndrome, and try and understand it within that context. So we know that young people, children and adults who've experienced severe trauma can show very strong responses to things that remind them of trauma. So that's the model of PTSD, if you like. Showing my age, I think about the Vietnam veteran who's safe at home, who hears the helicopter, who has a fully fledged response, a panic response, a huge anxiety, because at that point he or she is put back in that original traumatising situation. Very similar for people who've experienced other forms of abuse. People have difficulties managing anxiety, find it hard to deal with aggression, particularly people who've experienced physical abuse in childhood, where aggression, of course, has become the currency of relationships and interacting. They will have what we call disorganised attachment behaviours or difficulties in understanding that fundamental thing that all children ask: who is there for me? Is that a safe person? And of course these children, from an attachment perspective, have had a person there who's meant to be their attachment figure or the person or persons, depending on their social setup, but the person who is meant to provide feelings of safety and security, who at the same time is terrorising or frightening. Now that makes no sense. So that child is struggling with what sometimes is described as the paradox of maltreatment. I want to approach this person for feelings of security and comfort, at the same time I need to get away from them. So in a simple way, that's an approach avoidance conflict. And that's why we see these children demonstrating from quite an early age very confused behaviours in relationship with their carer, with a traumatising carer. Approaching and then suddenly stopping and not being able to go any further. Approaching with the hands over the eyes is a very clear one, if you happen to see that. I'm terrified of approaching, but I'm going to try it anyway. Approaching backwards. You see these little ones, 12-monthers, scooting around in a backwards way towards the frightening carer. So a whole lot of indicators, if we do those observations, that are showing us about the fundamental confusion and fear And it's disorganised attachment, that situation of unresolvable fear that from a biological point of view, if you want to think about that briefly, will mean that those children have associations with high levels of stress-related hormones, cortisol, adrenaline, noradrenaline, and that's likely to be the situation that impacts ongoing neurological development. From a psychological point of view, these children in relationships of disorganised attachment remain fundamentally confused about how relationships work. They have experience where sometimes their carer might be having a more positive response to them. They have many other times where they're frightened or terrorised, or that probably a more common experience where the parent is totally preoccupied with their own issues. So whether that's a parent who's depressed or thinking about their own past or confused, but who's poorly responsive to the child. Now, all of those experiences will have a negative impact on that child's developing understanding of human interaction and how to regulate themselves. So when people speak about affective dysregulation, they're really talking about states where children are highly aroused and anxious and seemingly haven't been able to develop capacities to deal with negative affective states. And sometimes, of course, even in very young children, we see the severe impact on development, and children who, when they enter into negative states, might be very disruptive or even self-harm. And we can see the beginnings of what later, if you think about the DSM system, might be labelled as severe personality disorder. Now, for children, of course, trauma-related syndromes can get labelled many things within systems, depending where they've gone. ADHD, of course, has been a very populist diagnosis in this part of the world. There's been maybe a bit of rethinking of that at the moment, or more community awareness that there might be multiple pathways to getting to this thing that we call ADHD. One of probably the most significant pathways is a breakdown of attachment and parenting and child maltreatment, and yet that's not spoken about very much. And maybe that's because we're not taking, from my perspective, a developmental model for thinking about the implications of trauma. The current big diagnosis, autistic spectrum disorders, or what used to be called Asperger's, and again, it's not that children who aren't presenting with difficulties in emotional interaction and social understanding, clearly they are. The question is, why? And we need to have a focus. We're doing some research at the moment trying to unpack this a bit about the ways in which poor care, maltreatment and breakdown of attachment can actually disrupt children's development of their capacity to understand emotions in themselves and others, or what's sometimes called mentalisation, the capacity we all need to understand ourselves and other people as having insides, and how this can look like what gets called, sometimes in a very reductionist way, autistic spectrum disorder, which must have a well-defined biochemical or genetic cause, depending on your theoretical understanding. Now, this is quite a difficult discussion to have within mental health services. I can only get away with it because I'm a psychiatrist, but people are then criticised from other disciplines for raising the issues. I don't think that's a very helpful thing. I think as a community we all need to look at, in a more complex way, at diagnosis. We all need to resist premature diagnosis. The main risk of this premature diagnosis is that it stops everyone thinking. It stops everyone thinking about the causes, other factors that might be contributing, other things that can be a focus of trauma-focused intervention. Particularly, it stops us thinking about maltreatment. And we've all had the experience clinically, I guess, where sometimes a family who are struggling would love a diagnosis because they have a wish, a very understandable wish, that the diagnosis leads to the pill and the cure. On the other side of the desk, I guess many of us are aware that the pill does not necessarily mean the cure, and cure is a relative word anyway, but there are a lot of factors that need to be looked at in a comprehensive intervention. So I'm not dismissing people's concerns, and many people, of course, are comforted in a strange way by saying, OK, there's a model that helps me understand what the difficulties are. Sadly, in child abuse work, we sometimes see children who are overly diagnosed by many parts of the system, from the parents to the treatment facility, and what gets lost in all of that is an actual focus on the attachment context, the parenting context, and what's happening to children in terms of maltreatment. So I think we're all familiar with that as a dilemma. What we do about it is probably more complex, but we do need to resist, in my view, diagnosis in the very young. And question diagnosis and its meaning as the sole approach to intervening with high-risk families and children. So what we're frequently seeing, whatever label we give it, is parents who are both traumatised themselves, sadly, this is the transgenerational notion, and traumatising for their own children. So we're very familiar with that sort of idea. But all parents who've experienced abuse, maltreatment, neglect in their own histories are going to face significant challenges when it comes to parenting. Some resolve them very well, others struggle. But we see a range of responses, from anxiety to avoidance of children in a self-protective way. So, for example, a parent who said to me the other day, I don't think I'll get very close to this baby. It's better that I don't, because something bad could happen. And that was a very clear protective strategy that she had thought of. But from the baby perspective, was really going to set up a relationship of that baby being very puzzled and traumatised by avoidance and potentially by neglect, so needs to be a focus of attention. In our work, sadly, we see repetition. And repetition of early dysfunctional patterns and abuse is something that we're familiar with as it occurs in an unprocessed, unreflected way, that sort of almost automatic reenactment of traumatising experiences that can very much impact on care. So many of the parents I work with are struggling not to reenact, but have impulses to do so. So again, a very important group of people we might need to think about in terms of interventions, rather than waiting for infant abuse to occur. As we know, it's hugely significant, and that the majority of children who die from child abuse are actually under 12 months of age. So we need to think about preventive approaches, better identification of risk factors, ideally, if we're doing that, in an antenatal setting. So we run some outreach services and consult to antenatal settings in my hospital and health area, where we have specific clinics for women with histories of mental health issues that might impact parenting, drug and alcohol issues, current social stressors, so women in violent relationships, the whole very broad range of factors that can impact on early parenting, trying to intervene at that point if we can. So the traumas that we're talking about, these early traumas, can have significant impacts, and we see the legacy of that trauma in the actual way that a parent might have difficulties interacting with their infant, or the way in which trauma from the past literally interferes with the relationship that parent's setting up with their infant. And in the literature, there's a very famous paper by Selma Freyberg, The Ghosts in the Nursery, where she very early on in the 50s spoke about the ghosts from the past of the parent that haunt, it was quite a nice metaphor, haunt the relationship that parent's trying to establish with their young child. So the parent themselves, who's still troubled by what happened to them, who has unresolved traumatic attachment experiences. And this concept of resolution and lack of resolution is an important one when we're thinking clinically about interventions. Of course, we see people who've had very negative experiences who to overcome those. Who might still be sometimes distressed by them because they were distressing, but they have managed to incorporate those experiences into a more positive understanding of themselves as a survivor of some difficulties. So resilience is always very important. The people we see in clinical settings who are having difficulties are largely those who have not been able to resolve or come to terms with their experiences. So to get the label of something like borderline personality disorder, essentially means that trauma lives on in the mind of that person in the present rather than being somewhere in the past. So the emotional impact of their experiences can be very current. And sometimes you'll have that experience when you're talking with someone who's been through huge amounts of trauma, and you suddenly realise that you're not very clear about what they're actually saying, whether they were talking about the past, whether they were talking about the present, because it's very confusing. Their emotional reaction to what's happened to them colours all their relationships in the present, including their relationship with their child. Now, you would think from some of this modelling and understanding of the impacts of early trauma that Australia would be in a great position to protect infants. And in fact, if you look at both political parties, there have been very significant policy developments which are important about child protection, about family support, and at least some acknowledgement of that. And I had to get it in at some point. Australia is not a country in which all infants are treated equally. Australia at the moment has hundreds of children, infants, children and young people in various forms of immigration detention who have no rights. And having just come back from Christmas Island, I can report to you that there is no child protection framework for the hundreds of children and young people who are unaccompanied without parents on Christmas Island. It doesn't exist. There are children, some with families who are in extremely deprived and substandard facilities with no toys, with no playrooms, with no access other than a couple of days a month for the older children to any educational activities, who are in a state of limbo. Children and families who are not processed in terms of the Australian immigration system, who are essentially awaiting transportation. I'm not sure of what words we should use for this, but transportation to Nauru and Manus Island. Again, I think you'll be aware that these are not countries with any sort of infrastructure for child development, for the promotion of child health, let alone for child protection. Now, we find ourselves then in a very strange place as people working in child protection. Many of us are putting huge amounts into protection of our children, of thinking, of trying to advocate, influence government, and we maybe need to think about having a human rights perspective as we do this, which says that all children within our influence have a right to care and protection. And this is a baby who I actually have followed now for some time, but this little baby was with a mother in the Woomera detention facility, which you might remember as a very dangerous place of breakdown of human relationships. And this baby's mother developed a profound depression, a psychotic level depression, so very severe depression. Was virtually unable to care for this child. And again, it was a system at that time without access to any specialist services or support services for a young baby in that sort of situation. And this child developed quite significant developmental issues and developmental delay as a result of neglect and what we call non-organic failure to thrive. That's a disgrace that happens in a country like Australia. But only 2 weeks ago, I can say that this is occurring on Christmas Island. And I'll report back when I get to Nauru. So we live in difficult times, but I think important for all of us to have a view on this. Not to have a view and not to take a stand on this, from my perspective, is to give it tacit consent to what's actually happening. I think it's important that those of us who work with children say that this is absolutely unacceptable. Thank you. All right, I'm getting the wind up. So I'll just summarise some of the issues that I think we can focus on. We know a lot about, I think I've probably said that, the core deficits that trauma, if we're thinking developmentally, is associated with. But most importantly, the last point, representations of self and other, how children learn about relationships and themselves. So the abused child, obviously, as you're well aware, can have issues with low self-esteem, feelings of guilt, feelings that they've been complicit in their own maltreatment, or that somehow they deserved that, the implications for future relational functioning. If we work in mental health with adults who have survived abuse, very similar issues. People who struggle with endless poor choices in relationships or being re-victimised, people who struggle with parenting. And I think Lenore Turk, although she wrote some years ago very important papers, but described the mechanisms by which what she called type 2 trauma, or chronic and enduring trauma, usually intrafamilial abuse, how psychologically that impacts on children. So obviously children will adapt to their and try and survive their situation, where we're familiar with that. But the other thing that we see frequently is this notion of repetition or reenactment, whether that's in play, which we obviously assess, but sometimes in identification. So the child who identifies with the aggressor or takes on characteristics of the person who, although they were frightening and terrorising, was actually, from a child perspective, the winner in that situation. It's interesting that a lot of the discussion at the moment about bullying in the schoolyard doesn't really talk about the family lives and potential abuse histories of children who are both bullies and victims. But from this perspective, that would be a very important thing to actually explore a bit more. All children and growing into adulthood who've had these experiences have profound anxieties, are often over-aroused, on the lookout for danger as a protective mechanism, as you can understand. It's very important for children who've experienced abuse to be on the lookout. And so from babyhood, these are children who are hypervigilant, scanning the environment. They might appear quite constricted and poorly responsive, but they're actually highly aroused. If we're going to measure things like stress hormones and all the rest of it, clearly aroused, on the lookout for danger, quick to act first, ask questions later, as a self-protective mechanism, as we see all the time. But importantly, for long-term functioning, underneath that, abuse damages people's self-concept and ideas of, about themselves, their capacity to control their situation, to deal with negative experiences. And people in their adult lives, of course, will present in different ways around that issue. Depression is very common, guilt, deep feelings of shame, but also confusion about the reality of what actually happened. And that gets me back to the point I opened with, that some of our role from this sort of perspective is to help us both at a social and governmental level, as well as family and individual levels, to acknowledge the reality and to bring some reality basis back to this discussion. We need, in my view, to be much clearer about acknowledging the profound effects of abuse and trauma in human development. When we have discussions, usually fear-laden discussion about rampaging young people in the streets of Melbourne or wherever, I think what gets lost in that, what gets lost in a law and order approach, not that I'm saying that might not be relevant, but what gets lost in the law and order approach is a relationship with history, with the fact that many young people are struggling with the legacy of abuse, that we haven't had systems and to actually better identify and respond to that, and we need to look at targeted interventions for some of the most vulnerable. Children in out-of-home care, children who we know have experienced abuse. We tend to have a very appropriate and maybe necessary risk identification, actuarial sort of approach. What we don't have are the connections that we need between mental health services, child protection services, let alone with other departments such as the Department of Immigration and Border Protection, as they're now called, where we can actually have an integrated focus, of course, from our perspective, which means that child protection and treatment for children who've experienced abuse and trauma is the core business of all human services. Thank you very much.